Barbara Smith. Thank you. All right. We've begun recording the conversation. We have a number of people that are joining us, so we will continue to welcome them as they come. My name is Julie Dargis, and I'm so pleased to moderate this amazing discussion today. I'm here with Lisa Hilme, the Executive Director of Core Group, and we have a wonderful slate of panelists that I will introduce in a moment. I want to first welcome all of the participants from around the world. Please let us know. Cape Town, South Africa, wonderful. Nigeria, please let us know where you're coming from. And thank you for joining us for this conversation today. We're so pleased to welcome you to the second installment of the summer series, and it's nice that you're going to be spending some of your time with us today. Our topic today is evolution of health education and healthcare, and we're going to look at this topic through the lens of digital health, digital solutions. And to achieve this, we will be in conversation with the lovely panel that you see on your screens. These panelists are thought leaders in the space of digital health, and they're also core group members. During this conversation, we're going to be highlighting how our partners and members are using digital health tools and solutions to promote equity and inclusivity, increase access and quality of care, and increase collaboration at the community level primarily. We will also discuss measurement approaches and how adaptation and learning is being locally led. So I'm really looking forward to that piece. We will close the conversation with a look into the future with an eye towards emerging technology in the digital health space. So that's what we have planned for you today. That's the format. Welcome everyone. For everyone that has just joined us, please put your name in the chat. We're so happy that you're here. Before we begin this conversation, I would like to ask Lisa Hilme, the Executive Director of Core Group, if you would please say a few words.
Yeah, absolutely. Thank you, everybody, for joining us today. I always love the chat box because we see that the reach is Greece to Uganda to Nigeria to San Francisco, California area. So welcome, everyone. Core Group decided to have this summer series to not only explore some of the emerging issues and identify how Core Group members are achieving impact and how they're reaching priority population, but also how we're showcasing some real creative solutions, how we're promoting best practice among our global partners. So we're really grateful for our Core Group members today that are joining us. And this is the second in a series of 4. The first dialogue focused on localization, and we'll be looking also at climate health and the climate crisis and health in the future. So look out for that one in the near future. And we are really, really excited for today. It's an important topic, but more so very grateful to feature our members, Hesperian Health Guides, ThinkMD, and Stanford Digital Health, who have been making an impact around the world and most importantly in communities. I'd also like to congratulate Hesperian Health Guides who are celebrating 50-year anniversary. I myself, as a nurse, and when I was a Peace Corps volunteer, have used their health guides for many, many, many years. And so I'm not going to say how many, but but I just want to say congratulations because it's really had an impact on my life, and it's exciting we're going to hear about the evolution from when I held that, where there is no doctor in a village of Niger, to where you are now. Mm-hmm. Our topic today is very timely. As we venture into 2023, we know that as a field, digital health is really experiencing this rapid transformation. Put a hand up for everyone who has tried ChatGPT and AI, but this is much more, right? We're going to be looking at the landscape of health, digital health in terms of healthcare, quality care, and how that impact is on local communities. Core group members today will share how their digital health tools, how their platforms, how their mobile applications, how their online access has really facilitated personalized learning, health education, remote training, and that real-time collaboration, while also breaking down some of those barriers of distance through locally led initiatives. I'm so excited. We have this fantastic woman panel of excellent leaders that is surging forward in the field. And we'll also be discussing with them today some of the challenges and ethical implications that are associated with some of digital health technologies and how we promote equitable access, how we promote inclusivities in the use of digital tools. So be active in the chat box, introduce yourself, and be prepared for questions, any questions you may have. This is an opportunity not only to learn, but to meet new people, to make connections. So thank you very much. And I'm going to turn it over to Dr. Julie Dargis again. Thanks, Julie.
Thank you, Lisa. Thank you so much. I would now like to introduce our panelists, please. Sarah Shannon is the Executive Director of Hesperian Guides. She has led Hesperian since 1996. Prior to joining Hesperian, she trained community health workers and managed community-based public health and development programs in Central America for 15 years. Sarah has directed the development and launch of Hesperian's online health wiki, which I've used for a number of years, the platform and mobile apps that extend the reach of Hesperian's trusted print materials through digital technology. Sarah is co-presenting today with her colleague Lori Berenson, who is the coordinator of partnership and research for Hesperian's digital resources. Lori is currently working with over 50 partners in 20 countries to collect feedback on the uses of Hesperian's reproductive health apps. Prior to joining Hesperian, Lori lived and worked in Latin America for over 20 years. We are also very happy to welcome Nopiwe Job, who is a research analyst at Digital Medic. She is a nutritionist by profession, having obtained her master's degree in human nutrition from the University of KwaZulu-Natal. She is currently registered as a PhD candidate in human nutrition at the University of Cape Town. So congratulations on that amazing work. She previously worked as a nutritionist overseeing the implementation of the integrated nutrition program in the department, in a health department in a rural sub-district of Umvoti in the KwaZulu-Natal province of South Africa, where she's coming to us from Cape Town today. Before joining Digital Medic, she was a PhD research trainee at the Human Sciences Research Council of South Africa in their population health systems and innovation unit. So we're really looking forward to what you bring to the conversation today, Nopiwe. And we also have with us ThinkMD's partner success lead, Barbara Martin. Thank you for joining us, Barbara. Originally from Uganda, Barbara lived in Italy for several years before coming to the United States in 2001. She attended college at Northwestern University in Boston, where she obtained an associate degree in management information systems. She later transferred to Vermont, where she's coming to us from Vermont today to attend the University of Vermont, where she graduated with a Bachelor of Science in Business Administration and a concentration in MIS. She pursued her Master's of Public Administration at the University of Vermont, which she completed in 2018. Today, Barbara is manages partner success at ThinkMD, and I'm really looking forward to that aspect of the conversation, and is actively involved in the Shelburne community. So I would like to extend a very warm welcome to all of our panelists. Thank you all for joining us today. To begin this conversation, I'd like to, I have a couple of rounds of questions. I'd like to begin by getting to know your organizations and as core group members before we look later on into the conversation into the future a bit. I'd like to start with the Hesperian team, if I could. Sarah, How has the evolution of these amazing guides progressed over time? And what are the key factors that have influenced the evolution of the Hesperian guides?
Well, well, first of all, thank you very much. It's great to be part of this panel. And as a longtime core group member, I'm really appreciative too of the core group space to share and learn. So Lisa, thanks for your kind words on Hesperian's 50th anniversary. We have been doing print resources for health education and health training and self-care for 5 decades. And we still do that. And actually what is relevant in this discussion, I think, is that we've always tried to we used an open copyright approach, and we did collaborative content development back before the internet, essentially trying to do open source before you could with internet. So I think our transition to digital was a way to facilitate what we were trying to do to make it better, make it easier. So I'll tell a little of that story, and Lori's going to pick up and talk more about it as well. But so we developed, for those of us that don't know Hesperian's materials, Where There's No Doctors, perhaps our best known book, but we have developed content on many topics and many different languages as well. Where There Is No Doctors in 85 languages. Our content is used in 221 countries and territories, so pretty much everywhere. And used by for use at community level by health promoters, community health workers, people who train community health workers and midwives, and for health education and health promotion, as well as facilitating self-care. Our resources are widely used to train and as a basis for health education curriculum. And I think we actually have a slide on this if you want to show it at some point. Sorry, we're co-presenting and figuring this one out. We launched an online platform in 2011 that essentially enhanced and facilitated our open copyright and collaborative development approach. It was designed from the start to be a multilingual platform. It now has 39 languages in it, and we keep adding more. So I keep on watching that. And it really has facilitated a lot of collaboration and enabled translation to happen much faster. And we'll talk a little bit more about that later, but that's kind of an overview of the Health Wiki, which is an online platform. The mobile apps is a sort of our third area of work. And after seeing high levels of traffic to our women's health materials, once we put them online on the Health Wiki, that was where everybody wanted to, that was just the most sought after material. So we began developing reproductive health apps and launching our first in 2012. And Lori, maybe I'll hand this over to you. Do you want me to put the slide on at all?
Yeah, I meant to put the slides on. Yes, we have 3 mobile health apps. The first that came out was Safe Pregnancy and Birth, which was developed to really foster safe behaviors, to train health workers to support safe pregnancy, identify danger signs, with lots of how-tos, very practical workers or community members or family members could do. We're actually in the process of updating that app, and later this year we'll have a new version of the app with new sections on mental health and other content, really fostering the wellness of the parent and the child through the first week. Then we have the Safe Abortion app, which is probably one of our most widely used resources, with ample information about safe methods of abortion in very clear language to facilitate use by health workers, from doctors to community health workers, as well as from people seeking abortions or activists and community members, to inform themselves and avoid the risk of unsafe abortions, as well as for those who want to make safe choices. It has a pregnancy calculator. It has very large section on frequently asked questions, how to prepare for before, during, and after an abortion, as well as some shareable information. And then there's the family planning app, which was designed to support both health workers as well as people seeking contraception. It has a method chooser. It has ample information about diverse methods of contraception and a very large section on counseling. So basically, how people who are not necessarily trained in contraceptive counseling can give respectful and effective counseling on a very, very stigmatized topic. And these apps are used all over the world, as Sarah mentioned, in the last 12 months alone, in about 195 countries and territories, as well as in both we have a web version which can be used online, doesn't require download, and downloadable mobile app which can be used offline, never has to connect again to data and or to the internet. These apps are private. We don't collect any personal data about our users. So it is designed to facilitate, deal with a stigmatized and also sometimes criminalized topic in a way that is effective and respectful and gets the information across to those who need it. The apps are multilingual and they are in 11 languages. This, as this chart shows, basically all of our resources have a continuous origin in participatory research. So we started with, where Women Have No Doctor which was developed over 20 years ago, was developed with participatory research with community members and different types of organizations all over the world. And that information channeled into the Health Wiki, which allowed us to disseminate this information in many languages. And seeing the use of that information is that informed the decision to develop the mobile health apps, again with participatory research with community organizations who informed what type of content was needed, and also the patterns of use of our Health Wiki. And the feedback we've gotten on our mobile health apps has driven a recent update of the Where Women Have No Doctor update that came out earlier this year, which it's a process of continuously, learning from people on the ground what is useful for both end users and others about what is useful for their work and their needs. So it's a very dynamic relationship between these resources.
Thank you. That's brilliant, Lori. And what a perfect transition for the next question that I have for Nopiwi. It's really great to see both those apps. Nopiwi, can you discuss the role of end users in shaping the design and development of digital education projects with Digital Medic? I'm interested on your thoughts on and insights on any or feedbacks that you have incorporated into design. So we have all these amazing tools that Hesperia is using. From your perspective, how do you connect? What is the role of the end user in the development? And from your side.
So hi everyone, it's great to be here. I'm going to share my screen. I will definitely try not to be long. I'm very long-winded. I'm those people who can talk forever. So Julie,
I'll give you a tickler if you need. Yeah.
Be sure to stop me. Friends, we are Digital Medic. I work for Digital Medic. I'm a research analyst, and I've been working with Digital Medic from probably the end of 2018. In fact, when I came to work for Digital Medic, they were working on a big RCT where they were showing breastfeeding education content to the community via community health workers. This was really my first time merging the worlds of digital and day-to-day community work. I'm very familiar with the community health worker space. I worked a lot in rural KZN with community health workers. I trained them a lot. So, I mean, I came to the right place, and I was watching community health workers have a new tool to use to engage their clients. Today, I'm going to give you an example. I'm going to give you an example of how we can include end users in the work that we do. I won't give you that example of the RCT, but I'll tell you another interesting one we did. I think when we think about end users, we need to we are not only thinking about the end user as a client sitting at home, but sometimes our end user is the community health worker or the health worker themselves. And sometimes how we sit down to approach content development and creating all these tools, nobody creates a tool for it to not work. Usually in the room, we have a number of people. We have the designers, the production specialists, medical illustrators. We have medical experts who know the content, who know the work. We have organizations that are interested in the work, community health worker groups. That's very near and dear to Digital Medic's heart right now.
Okay, wait, forgive me for interrupting. We have a beautiful picture on the screen right now. Is that what you wanted to share with us?
Let me see what I'm sharing.
It was very colorful. There we are. Brilliant. Please continue. Thank you.
So we have sometimes government officials, ministries of health, and learners, whoever it is, this end user that we want this tool to reach and really to help. So when we're sitting in a room and we're creating something, there are quite a number of people, but really we want to know if the person we are creating for will actually use the tool, find it useful, and easy to use. I think there is no shortage of health education. That is true. You can find PDFs upon PDFs, books filling libraries, but actually our heart is simplifying, making it accessible, making it adaptable and palatable and easy to use for any frontline worker or community health worker, or really a user, someone who is sitting at home. How we think about this, we like to call it iterative human-centered design approach. We usually start by gaining insights on the context. What are we trying to do? What is the problem? Identify any barriers, talk to people. This is particularly important. Our content team fights about this a lot. They want it to be done early. What are we doing and why? Because there is no reason why we should create any new information. But actually, because information is always available. But actually, we need to go back to the drawing board and say, who is it that needs this information? What is the problem and what are their barriers? Then we go on to say, okay, let's design something. Let's come up with a plan for it. What will it look like? And then develop it, implement it, test it, but constantly in conversation with this end user of how this is are we still on the right track? Is this still useful? Is this still usable? Does this actually solve any problem? I'm just going to move on to an example that I would like to show you that we conducted recently, just to speak to the end user idea. We worked with Community Health Impact Coalition to create a community health worker tool. This is an advocacy training manual. This is a very practical example. This is a training manual that we definitely had content for. We knew exactly what should be in the advocacy manual. We understood what key concepts of advocacy should entail. We were the researchers, the experts, the curriculum developers, and we said we know what the content is and we put it together. We worked together with the CHIC group, Community Health Impact Alliance, and we said to them, you have community health worker groups, and we would actually like to talk to community health workers, not their superiors, not their supervisors, not the managing director of the organization, but we'd like to talk to community health workers. We know that they work as advocates for their communities, but we are creating a course that would educate community health worker at their pace, self-learning. We want to know. We want to talk to them and we want to co-create this thing with them. We have the content, but we don't know if it's relevant. We don't know if it makes sense. It sounds beautiful. It's beautiful in terms of, what a construct should have, but we actually don't know how usable it is. We put together a group of about 25 community health workers working in different parts of Africa. And we got together. This was a 6-month period. We came up with the curriculum, we sat down. And over a 6-month period, we consulted with these community health workers. We met up on Zoom to look at the content, to analyze English, there's a picture here I put of a character development. We had a persona that developed, Sarah, who is the one narrating the entire course. I mean, the amount of changes Sarah went through, all because community health workers said, this person does not look like a community health worker. And I don't trust anyone who does not look like they could be a community health worker. Sarah went through so much. I put an image of a backpack because among other technical things that we discussed her backpack for such a long time. These are things we don't think matter in overall how content looks. We want to be technical, want to say, here are the sentences. This is the work. This is what we should, this is ABC. But actually we realized that the more we engaged with community health workers, even the feel of the course changed. We had many more videos, demonstrate what you are saying. If you are using something to demonstrate, to explain something, it better be an example we understand. That community does not look like a community. The buildings you used at the back do not look like a building that we are familiar. That does not look like a community. The English you are using, we can hear you, but there are a number of questions I have. What is this word? What is that word? Or you've used too much text. I think you are taking away from what we are doing. So out of sitting down with community health workers to design that course alone, I mean, I can say, oh my God, we could not have thought about how much value that would have in actually causing the course itself to be sent. Because those 25 community health workers, when we sat down the second and the third time, they said, I actually showed this portion of the module to some of the community health workers. We had a problem understanding this graph. We had a problem doing this. We had a problem navigating the app. We had a problem, we had a problem with the assessment. We had a problem with the way you asked the question. Among those were kind of things that are like, not even a refresher, but like a game you would play to say, how well do you understand this? And sometimes they wouldn't land. We came and we argued in these sessions. A picture you see down there is a Zoom page where all the community health workers have come and we are talking about a particular thing, and we are just, no, this exercise is not doing what it's supposed to do. We also had a WhatsApp group open while designing this course. And every time someone went through something, they'd say, I'm going through this section of the course, and this does not look right, or this information is wrong. This is not how we do things in Kenya. So it really helps in contextualizing and giving real usability to the work that we do, to constantly be in communication with the people you hope will use the tool you are creating.
That's really fantastic. Really the word engagement, really engaging at that level and providing voice and choice in the iteration process. But so importantly, with the simplicity, clarity, right? Clarity, simplicity, and my new favorite word, palatability. Another word for user-friendly. So we have these amazing tools. We engage we engage with the end users to develop them. And I'd like to move over to you, Barbara, now. And in terms of moving from design to analytics, right? Once we have the tools in place. Barbara, can you tell us what challenges ThinkMD has encountered when applying research and analytics to inform clinical decision-making at the community level? So how have you addressed these challenges, and what lessons have you learned? And thank you so much, Nopiwe.
Thank you, Julie, and thank you for having me. Happy to be here. So I'll give you a quick background on ThinkMD. So ThinkMD is a global health technology company that has developed clinical intelligence software that guides a user to make high-quality clinical decisions at the point of care. And I have a few slides I can share them after the session. So what our technology does is to it's been proven to be accurate and usable by a range of users. The software is live in now about 10 countries, used by about 4,000 users, which include doctors, nurses, community health workers, teachers, and individual families. No matter where care is delivered, our aim is to unlock the clinical capacity in every role. The software can be used online and offline. It's easy and accurate, can be translated in any language, currently in 16 languages, covers more than 350 of the most common acute and primary care conditions, can work seamlessly across different operating systems, which allows the user to pick the devices that suits best for their needs. So when the platform is in use, we acquire a robust set of data at the point of care. We work with the implementing partners to be able to relate the data, and what they're looking for are trends in the primary health conditions impacting the population. What are the changes in the conditions they are seeing that impact that population, and what do they need to react to? Are they seeing any spikes in illnesses? We also measure the program performances and also the workforce management. So a number of challenges that ThinkMD encounters when applying research and analytics to inform clinical decision making at the community level include, and I have a number of them, but I'll just focus to about 3 of them. So number 1 is the adoption and end user buy-in. So when we are introducing any new research and clinical methods to communities, you have to think of building that trust. You need acceptance and understanding among the healthcare providers, patients, and any stakeholders you're working with. So it happens to us, probably most of you, that the decision makers are often not the end users themselves. So it's important for us to keep the users involved in the process right from the start. The other challenge is understanding the data shared at that community level. We find that not everyone is a data specialist or is able to analyze that data put before them. So helping that end user looking at the data to unlock any key insights that can help them find the trends or any insights that are important to them. So when we put data in front of the end users, we try to drill down to those specific indicators to make sure that we are helping them see the value that can show them success. The other issue is also around the social, cultural, and language factors. So this can affect the understanding and acceptance of that research and analytic-based clinical decision-making tools. So ensuring that the information provided is culturally appropriate and comprehensible to the community members is crucial to making that implementation successful. One last one, because I think this is important. Usually what happens that most of these community level initiatives often face financial constraints. They don't have skilled personnel, expertise, and this can hinder the implementation and sustainability of the research problems. So what has ThinkMD done about this? How do we approach these challenges going into such programs. So one of the things we do is to make sure that we are hiring in-country implementing partners that can help train, work closely with our partners, with the local health workers. We make sure that we are collaborating with the local stakeholders and communities to ensure relevance and cultural sensitivity in the research and analytic efforts. We actually try to engage in partnership with the government and non-government organizations and other stakeholders to leverage any resources and address limitations collaboratively. And lastly, one of the things that we do is to encourage that knowledge sharing and collaboration among the partners network. So some ways that we've thought of going forward with this is use forums or use office hours where we have an open line and anyone can dial in and ask questions on the different topics.
Thank you, Barbara. So we've put forth a number of different approaches and tools, and thank you for sharing the backgrounds with your slides in that kind of the initial launch of this conversation. I'd like to now just have more of a kind of a reflection on some of these things, and I have a couple of questions for you now in conversation to discuss really around. One of the aspects of digital tools is their potential to reach such a wide audience. I mean, Hesperian, we talked about hundreds of countries, hundreds of languages. Lori, in terms of inclusivity, how have you ensured that the health guides reach a diverse population of users from varied language backgrounds with all of the countries that you're covering? And can you also speak to the strategies and talk to us a little bit about the technologies that have been employed to achieve this?
So I'm going to start and then Sarah will follow. But first of all, it was wonderful to hear about the experiences of the other colleagues on this panel. It's very interesting and very similar in many ways to our processes. So speaking of inclusivity, I think there are two ways that all of Hesperian materials really approach this. One is the inclusive, the way that we develop the resources comes from community health workers and other people on the ground requesting or needing, seeing what people need, and that really is what sparks the development of the resource. But then from there, we ensure that the resources include the stories as well as images that are real people, so that people see themselves in the resources we have. Our images are very, very well known and used precisely because of the way they actually show people as they are, and people see themselves and therefore use them in training guides and in other things. I also think the other fundamental thing is after the resource is developed, we get it tested, we see how people use them, and then track how people get a sense, hear from them how they're used it, to get a sense of how we can improve the quality and adapt and update them going forward. We've had a really, really substantial adaptation process of collecting feedback and adapting and fixing the apps, fixing things online, and even, as I mentioned in the last time I spoke about, informed an update to one of our most used books. So I actually have 3 cases of community outreach field testing here, one from Ecuador, one from Cote d'Ivoire, and one from Tanzania. And this is all with our mobile apps. In the case of the mobile apps, which is actually because it's not a print resource, it's something that it's a little bit easier to adapt and to update more frequently. We do have a practice of updating it almost annually, if not more than once a year. And it's through this hearing how people are what we call user testing, or getting feedback from the type of users, either end users or health workers, community leaders. We've worked with we've tried to seek the most diverse range of partners possible, from midwives to doctors to community health workers to teachers, to sex workers, to a range of other students, a range of users. And this has allowed us to find ways of making the app more useful for them. So one of the things we've added to 4 languages now, and we're planning on building it more, is a read aloud function. So on the par of the content that you see on the screen of your phone or of your computer or of your tablet, you can have it read to you. And that's working in 4 languages right now, with more to come. And that's been a huge thing for people who are just either not used to reading or have lower literacy, which is one of the main challenges for sharing a lot of information, despite the technologies that we have. We've also gotten a sense of, we've developed, in the case of the Safe Abortion app, we have a section called Information for Your Country, which talks about the laws, which talks about the type of organizations that can help you, which describes how to get through the process of a legal abortion in the cases where abortion is legal. So there are ways that we've implemented the feedback from partners in order to make the resources more useful for them. I don't know if you'd like to continue here.
Sure. Okay. And I'm actually going to move to a different slide, maybe. Actually, I'm going to stop sharing, Lori, and have you do that one.
Okay.
So one of the, I'd say, best examples of also this kind of collaborative process and multilingual development that is facilitated by our online platforms is the response to COVID, actually, which was, obviously really, as everybody knows, it hit us all fast. But by the 1st of March, we had developed an initial COVID fact sheet in English and Spanish, which we released, I think it was March 2nd. It was released in French March 3rd. And by April, it was in 29 languages. And that was because folks found it and wanted to translate it, wanted to have it available in their language for their use. And we were able to disseminate it for them really quickly with the online platform, producing also a printable, downloadable version that then people could print and distribute as flyers and handouts. So that was, an example of very rapid kind of spread of content that people were adapting as much as possible to their situation. But the other thing, of course, that was happening is that, are we screen sharing?
I don't think so. 1 second.
Okay, let's just do that here. I'm going to do that now. Sorry. Here we go.
We love seeing you also, your faces.
Yeah, that's fine. Let me just, I'm not sure that this is working right, but maybe Lori can drive it from here. I can't walk and talk at the same time. Well, actually I can, but as everybody remembers with COVID, there was constantly new developments happening. It was no masks and yes masks and this and that and the other. So we were also shooting updates across what eventually became 32 languages in a sort of a constant switch and back and forth, where sometimes it would be updated in Amharic before it was updated in English. So there was a really interesting collaborative process here where we were really in touch with collaborators around the world, constantly updating this stuff. We ended up developing with folks 10 COVID-related fact sheets, that some of which they developed and we translated into English so that then it could be translated into other languages. So it was definitely this kind of multi-directional collaborative process that is at its heart, I think, what online platforms are really well suited for. And so that's just a great example of sort of the strengths of that approach. I think the other aspect of inclusivity, and by the way, this screen is showing some samples of the COVID fact sheet. One of the things that people adapted the most was the face shield. Folks really loved that. We'd actually developed it for totally different use with our workers' health and safety materials, and we're able to quickly add that to the fact sheet. So.
Well, thank you, Sarah. And if you allow me, before I go to the next question,
Well,
the next.
I just talk
Oh.
briefly about shareability?
Oh, actually, and that, you know, it's a perfect segue, because I wanted to say we had a question. And the question was that one of our participants is interested in how you manage the increase in reach and uptake of the app. So I wanted to insert that question from the participants into the conversation, and I guess this is where you're going with it. So that's
Sure,
great. Could you
actually,
talk a little bit
perfect.
about
Thank you.
the demand channels and stakeholders that you marketed for the app in your response, please? Thank you, Sarah.
Sure. I mean, it's amazing sometimes that people find these resources all on their own. We certainly did our best in the case of the COVID fact sheet to broadcast out, but I think the apps is a really good example, in fact, of how we've sort of built in design for shareability. The whole idea is that people find this information, but then they turn around and share it as health education and others. So, for example, our print books are shared with an average of 40 people per book. We found that over many years of research. And we found out very early that people were also trying to share the content of the reproductive health apps using screenshots and then sharing them over like WhatsApp or other chat platforms. So we also have, while people continue to do that and we're thrilled, we've also developed some things that help them do that. We created some infographics embedded in the app that they can then turn around and share, and it just makes it easier for that. And they turn around and people share it over social media as well as their WhatsApp or WhatsApp groups or other sorts of ways that that information is shareable. And then we do use social media, and that's actually something else to just sort of point to, is we've been sharing nuggets of content over social media now for some years related to our apps in particular. And that in turn really amplifies the reach. So for example, last year we reached about 70 million with content through social media by sharing smaller nuggets from the app, which in and of itself is smaller nuggets that over social media, that then drew folks either to just share that piece of information or to come and get the whole app, depending on what they wanted and needed. And again, the app is online and it's downloadable and offline.
Thank you, Sarah. You know, high frequency of information, but in low dose, right? Low dose, high frequency, micro nuggets and micro education. And that's really where we're going in the digital space, isn't it? Because our attention spans, no matter what our generation, has been truncated. Nopewe, I'd like to turn to you for a moment, and thank you again, Sarah and Lori, for responding to that question so nicely. Nopewe, can you share some examples of successful collaborations? Let's move from the inclusivity question to then, you know, when we're working with a wide variety of partners and communities, what are some partnerships or collaborations that have been established to support that locally led digital efforts from your side? And I'm really interested to know how these partnerships have impacted the reach of the programs or of the solutions. If you can maybe talk a little bit about that.
Sure. I think this is not a platform for me to explain the importance of partnering locally for any work we want to do. It doesn't matter how important we think our cause is or our message is, but partnerships are things we do because we understand that trust is important when information is shared, and particularly when health information is shared. So we have worked with a number of collaborators. Actually, I should share a slide for that just to show our reach.
Sure.
Wow. My computer is saying no.
And
Okay,
now it's saying yes.
yes. Now I have to pull in the screen. I actually would like to show you. There we go.
Okay, thank you. It's clear.
Perfect. We really do value the idea of collaborations, but collaborating with organizations that work on the ground, because we understand that trust is important. People need to know that the information they are getting is trustworthy information, particularly in the world of misinformation, and especially what Sarah and Laurie had been talking about with COVID-19, where we had to get information out quickly and so on. I'll go back to the example I spoke about last time of a collaboration we had with Community Health Impact Coalition. They are a coalition, and they, of course, have a number of organization members. When we created the advocacy course with them, with these community health workers from the various organizations, we thought definitely they'll get the app. Community health workers will use the app. But what we quickly learned throughout designing the app was that the app actually would not be able to be accessed by everyone. There would be a couple of community health workers maybe in that area who could have the app. And the community health workers quickly advised us, you will have to create a facilitator guide. You will have to create a learning. It doesn't matter how concise, how small it is, but something that will help us to train, because we are going to train. Now, we could not have, as Digital Medic, been able to train community health workers throughout, say, the African region. We would not have been able to do that. But because we worked with these collaborators, these organizations who gave us their community health workers, they said, no, create something that we can also use offline. It's very similar to what Laura and Sarah were sharing about how things need to be able to be downloadable. I need to be able to adapt it. One of our vaccination toolkits, an organization can put their emblem on it, because we understand that our partners are the people who are trusted in their communities. Now, continuing on that advocacy course example, that course was taken on by Uganda community health workers. They spoke about it wherever they spoke about, and then influenced their organizations that, you know what, this is a great course. It taught me, it gave me identity. I think I understand what we're doing. I see who I am as part of the health workforce. It helped me with this, that. And right now, the Ministry of Health Uganda is going to roll out this course to train their entire community health workers. We could not have done that. Digital Medic definitely did not have that reach. We could not have even spread the word to the last mile, the person who has no app, who has no access to our website. But because those collaborations with these community health worker groups, we partnered with them. We knew beforehand to create something that could be used for training. And now they are rolling out to community health workers we could have never reached if they did not have a digital tool. So the digital world, definitely, it was our entry. But right now they are rolling it out with partners. Nama Wellness team is training, and they are rolling it out in person. They are doing this hybrid thing that we want to see happen. We are going to study that, and we're excited about it. But another example is we are trying now to create like a refresher training with community health workers. We are working with Pilani. It's an organization in South Africa. We're working with an organization in Kenya, Lwala Health Alliance. We are working with one-to-one organization in South Africa. And we are realizing that even how this whole refresher training could have looked. The issue is not to digitize training per se. That's not what we were trying to do. We know that community health workers walk around with a big folder that has all their training. What we're trying to do is say, listen, which topic should we concentrate on to give you a quick refresher, or maybe a skill, how to do this? What would you want to know? And we sat down with these organizations to do that. The reason why we can collaborate with them is that we worked with them, we consulted them before, and we said, listen, how can we make this adaptable? We made something that they thought would be useful, but I mean, we cannot undermine having a collaborator in particularly when we create these tools, I think all of us are trying to reach the last mile, the
Yeah.
person who not have access to the information. And partnerships and collaborations are everything, because they are trusted by the community, and they will definitely cause your tool to be, you will change it so much such that it is so useful, much more useful than you thought it could ever be.
Thank you, Nopiwe. Now, I have an interesting question that's related to what you just talked about in terms of investment in partnerships. I'd like to pose that to you just to bring, bring it to the next level a little bit. From Lizelle Engelbrecht, we have the question, does the cost of developing the app materials, all of the hours with expert inputs, et cetera, justify the changes made in terms of opportunity cost for the money and resources spent during the process? So I think she's asking about the investment, and is there an example of a cost benefit tool or conversations criteria you have to justify it so it works and it's useful and it creates engagement? But how does digital medical look at that in terms of investment?
Woo, interesting.
It's an interesting question, isn't it?
From Liesel, and a difficult one to answer, a very difficult one to answer. In fact, we were working on a project with the WHO, and we were saying, friends, we know that the material we create, in actual fact, it's very difficult to measure also impact. It's just difficult. It needs a lot more financial investment, hours, research, methodologies, just ideas. It's so difficult to do. We were actually having a conversation saying, we already know that the tools we create are taken by someone, say someone, I'm in Nopiwe in my community, and I am going to sometimes translate it, sometimes adapt something, change something, a wording, and I'm going to use that to train maybe a group of professionals, 100 community health workers, or share it among my patients. How do we even quantify that multiplier effect? How do we even measure that? How do we truly know our true reach? We know it's worth it, but the measuring impact is so difficult. We really just rely on waiting on time and seeing bigger indicators of change in behavior. We also really await on, we were having this conversation with Luala to say we wait on seeing district indicators. So for example, in an area where you do something, where you look at say you give an intervention for breastfeeding, all you can do is see if other indicators in their clinics, where the community health workers work, is there improvement? How much percentage do you want to see improved? How large is the community? Actually, how far reaching can your tool actually go realistically? How many people in that community have WhatsApp? How many could have received the message? If it's IVR, how would you measure that? So we wait on other indicators to improve, other indicators being the clinic's information, the stats from maybe the community health worker, depending on where you are gauging this intervention. Look, we are all trying to measure that. I think everyone is trying to measure it. Right now, we are measuring eyeballs on the material. We are measuring feedback from users. We are measuring change in maybe behavior change in the small things we want to impact. But larger impact is an interesting one to measure.
Thank you, Nopiwe. Barbara, it just kind of a connection to that thread of the conversation. Could you, staying on the topic of partnerships, could you share some of the key partnerships that ThinkMD has established recently, and how these partnerships have enhanced your ability to utilize research and analytics in clinical decision making?
Thank you, Julie. So one partner that I want to call out in particular is Healthy Learners. They are a nonprofit organization based in Zambia. They are bringing healthcare to students where they are in schools. The organization trains health school teachers to not only teach students, but also to provide healthcare services as needed. So currently they are roughly in 400 plus schools, using the platform with maybe about 3,900 plus school health workers. These are the teachers that we refer to as school health workers. They are serving roughly, I would say, 700, maybe 700 and plus thousand learners. So the adoption of the ThinkMD platform in this program has transformed the ability to impact the students and the health via high quality and cost-effective health services in the whole of Zambia.
Mhm.
So this has made the Zambia schools become a new access point of care for an overlooked population, if you think about it.
Mhm.
So students are assessed in an established sick room at the school, and they're referred to a clinical, a referral clinic as needed if there is, complications. So some of the expected impacts from this better access that we've seen include reduction in absenteeism. There have been reduced childhood morbidity, reduced risk of stunting. There is increased vitamin A and deworming coverage. There is increased confidence from the referral clinics. And most importantly, there has been increased satisfaction for the school health workers, the teachers. The program is scaling with quality, and of course, the support of the Ministry of Health, Ministry of Education is very critical. Some of the advantages that we're seeing is increased compliance with the approved guidelines. There is reduced need to retrain, as they scale or move from one zone or district to another. There is reduced needs to retrain from ThinkMD. We've seen seamless data collection resulting from this workflow. There is, with our data analytic platforms, we provide reports that show the workforce management, population health monitoring. We are providing automated reports, which they're utilizing for all their schools as they think about improving their current processes or what they can be doing different as they continue to scale. And I think most importantly, as I mentioned before, that confidence and assistance to the school health workers is very has been very positive.
Thank you. Yeah. Mhm.
And
Please.
just one line, and I finish because
I have a question too, so it's hopefully it'll be related to what you want to say. So please say it, and then I'll ask the question in case it's not.
Yeah, no, I was just going to finish up by saying that all these programs allow to scale exponentially, both in rural and urban settings.
Mm-hmm.
Thank you.
Oh, that's brilliant. We've had such interesting questions from the chat and from the participants that I've been able to weave in that have been related to what you've been talking about. And Barbara, one came in for you that connects what you've just talked to us about with your original presentation of some of the tools. And the question that we have from the chat is, are there any interoperability challenges? And could you just talk about that a little bit, and especially now because you're looking at going into schools and then connecting with the medical workers through the education points. What would you like to say about that?
Yeah, so I would start off by saying we actually recently achieved data interoperability with the Kenya Ministry of Health instances of the DHIS2.
Okay.
Whereby they can see And this is one of our other partners that I didn't mention, that's Save the Children Kenya. So now we are able to integrate that information from the system and the Ministry of Health. So the other piece, talking about interoperability and, whether ThinkMD has faced some of this challenge. So we are designed to be integrated friendly. And it's important for us as we grow, as we grow our software, to think of that, how do we talk to these other health information systems. So we have done some integrations, like with case management platforms like Open SRPs. Again, we continue to, we have other partners that, of course, like some of the countries that are asking, how do we have existing platform, can you talk to us, can we integrate that? So those are some of the things we continue to think about. But I think what is to answer the person's response, I actually, the question I had already texted it out, but that's pretty much, yes, it's something that is on our radar at all times.
Thank you, Barbara. I do appreciate that. Before I move into the next segment of the conversation, where we take a look into the future, we do have a really interesting question that I think will ground us in the present. And that question is, with all of the work you're doing in partnerships and collaboration, I'm going to just open this up to the floor, to all of the panelists, for anyone who would like to respond. What is your collaboration with the ministries of health in the countries where you're working? Which I think is a critical question. Yeah. So the floor is open for any responses that you'd like to share with us. Sarah, you look kind of on the edge of your seat.
No, I was just contemplating what to say other than that it's challenging. But for example, we have been working with the Ministry of Health in Ethiopia to make sure that our reproductive health apps are usable by and rolled out to health extension workers in multiple languages in Ethiopia. So trying to make sure that our content is adaptable to, frankly, changing protocols and keeping those sort of aligned is honestly challenging, because we create a global product. We operate off of WHO guidance, but then obviously each Ministry of Health has differing guidance. And so there's a challenge there just about keeping everything sort of fitting in an overarching global framework and localizing it enough that the Ministry of Health of Ethiopia is comfortable. And then there's also issues just about, like, Afan Oromo is not a language that everybody's fully agreed on around conventions on spelling, for example. And so there's, multitudinous feedback on this spelling, no, that spelling, and things like that are always a little interesting. So that's just one example, I think, of some of the challenges, but where we've really relied on local partners to work, because we're a smallish organization based in the Bay Area. So local partners are really the people that end up interfacing with the Ministry of Health, and we're a partner with them. So that's really how it's best worked for us. They understand the landscape and they'll know how to sort of work with their ministries of health, and then we're supporting them in that process.
Thank you, Sarah. Napewe or Barbara?
Yeah, I would. Yes, I would agree with Sarah and Laura on this 100%, because we also at ThinkMD, we rely on our implementing partners who have close relationships with the ministries to help have that interaction. So then we work closely with our implementing partners, because we can't pretend that where we are, we understand the government's, logistics and all the bureaucratic that may exist. So I think having that close relationship with your implementing partner and using them in that realm would be the best way to do it. And that's how we manage it too.
Thank you. And Napiwe, did you want to add anything on that question? before we
Definitely.
move? Yeah.
Yes, definitely.
Please.
Look, I sing the same song. We are very closely linked to our implementing partners. We've had luck with working with local government in South Africa in developing actually a whole series, a breastfeeding course, a video story kind of, where we actually could send back and forth the script with the and they check the script to see if it's according to the guidelines and if
Right.
everything they want to be there. We've had luck, but it's even better if you work with implementing partners who then can continue on the relationship. Also, that is a bit more sustainable.
Yeah, thank you. I know we also have someone from Maternity Foundation who's a participant, and they have a maternity app, and they are working with WHO and UNFPA with the larger global guidelines, and then bringing that, which is wonderful at the country level. So I think the point here, as I read the question in terms of collaboration, is really that respect of the national health policies and supporting the development and the direction of national governments in terms of setting their health policies. This has been great to get a sense of who you are and what you're doing in your tools. And I'd like to take just maybe some shorter answers now. So we'll save a little bit of time for some more questions. We've had some great questions. We've woven them into the conversation to date. So if there's any other questions, please, from the participants, put them in the chat, and the panelists will engage with you and we'll pull some out. But I would like to take a look into the future now, because there has been this amazing proliferation of all these new platforms and tools. And I have just a question for each of you, if I could, to see where you're going. Let's start with Sarah, please. Looking ahead, Sarah, what opportunities do you see for further enhancing your health guides? And specifically, what are the emerging technologies or trends that you're tracking that you expect to incorporate in the future?
Sure. Well, I mean, our basic philosophy is continuing to offer different ways for people to use different technology they may have access to in order to access and use content and make it as shareable as possible. So, that's how we approach any kind of new technology developments. In terms of, Lori mentioned briefly text-to-speech function in our apps. Right now, that's still limited by because we use the innate capacity. So certain languages are not supported yet, but that is changing all the time, and we're looking forward to expanding the text or the read aloud feature of our apps to go beyond the sort of colonial languages and into other languages that folks speak, as that kind of support exists. So that's certainly a technology we're watching all the time. The other thing, of course, is that we're continuing to expand languages in the Health Wiki. And that's really and I'm going to make a pitch for partnership here. Because stuff ends up in the Health Wiki in multiple languages because people want to use it in their language. And so if there's something that we have that would be helpful in your work, in the wider core group network, to put into a new language, just be in touch with us. And the online platform really facilitates the translation and production process. So
that's great.
It's possible. And then in terms of some trends, I'd say one of the things that we're doing, and this is again pitch for partnering, is we're developing a lot of new content, and we look for partnership to help us develop collaboratively and test that content. So topics related to fracking and plastics, mental health, and epilepsy and seizures are currently topics we are preparing to do more testing on, and we're looking for partners. If any of you all work on those issues or want to, reach out to us, please. And then we're always looking for partners to tell us how they're using our resources. And we will be launching an open beta of our new Safe Pregnancy and Birth app. It's a totally new version of one of our our longest standing reproductive health app. And just kind of a shout out there, if any core group members would like to participate in giving us feedback on that beta, we will love it. So that's just a little bit. One thing I
Yeah.
want to talk about briefly is social media, however. You know, it's an opportunity for us in the future. It's currently an opportunity, but it's also fraught due to content suppression. And I just want to sort of flag, I don't know if anybody else works on the content of safe abortion, but there is a network of organizations forming who've experienced content suppression sort of systemically around topics related to reproductive health and rights, including information around contraception, but definitely around safe abortion. If that's something you're interested in learning more about, please reach out to me. And then I think when we think about social media and generally the sort of larger sort of sphere, we need to think about the negative trend that's misinformation. And in response to that, we're really doubling down on our commitment to providing reliable, trustworthy health information that is up to date. But I do think this issue of sort of dealing with misinformation in the health sphere is something that we need to collaborate on more broadly. So I'll just sort of highlight those as issues.
Thank you. Thank you, Sarah. Now, Piwei, are there any specific technologies or platforms that have proven particularly effective in delivering locally led digital education? And how will Digital Medic adapt these solutions in the future?
We have an app, and we thought initially we have an app where you can download our courses or whatever content you require, and it'll be available offline for viewing on the app. What we've learned now with working with various groups is things need to be downloadable for sharing on WhatsApp. WhatsApp seems to be, particularly in the areas that we work in, WhatsApp needs to be utilized a lot more. We're thinking about how we can incorporate some vaccine education on a bot using WhatsApp. You know, we're exploring that idea. We need to, of course, figure out how we still want to know how many users, how many eyes were on the content, and we're thinking about that. I think we're realizing the power of social media, and particularly WhatsApp in LMICs and in low income areas. We're trying to get our work as downloadable as possible, shareable as possible. That's what we're really trying to prioritize right now.
Thank you. Thank you so much. And Barbara, for the future, what are some of the notable technologies that, or some technological advances that you might be tracking in research and analytics for clinical decision making? And what impact might these advancements have on healthcare delivery in the communities in the future?
So we have proven through research that digital tools are empowering users with clinical expertise. So for communities, that means that they are no longer reliant on traditional healthcare facilities, you know, or they're they're not relying on the doctor offices or clinics to receive care. So they now have the clinical expertise in their homes or workplace or schools. And we know that they're receiving the quality of care they need at that point. The other piece is also, we have proved that with minimally skilled, trained front health worker, they can adopt a technology that helps increase their clinical capacity that complies with the WHO and Ministry of Health guidelines. So those are the main points I can think of. And also maybe also the empowerment of these community health workers or school health workers that they receive from the utilization of our platform, which helps them assess the situation of an individual without having that 4-year degree. So I think that's a huge advancement.
Thank you so much. So we've had some very interesting questions along the way throughout the conversation, and I've been able to weave those in. If there are any other questions from the participants, please, we're happy to open it up if you'd like to ask, or if you'd like to ask directly, or you can type them in the Q&A section, whichever. We have a few more minutes with this amazing panel. And you can raise your hand to be called on, and Kate will help us to let you in if you have a question. I really appreciate all of the insights that you've provided to us, this amazing panel. It's really interesting, and just to recap some of the highlights, once we have our solutions, all of these amazing solutions that that you're working with, I really did appreciate learning about the community level, the collaboration, the engagement with the community, and really the reach is just amazing for all of these solutions. For core group, I would like to offer Lisa the opportunity to just touch base with us and let us know how we can connect to all of the resources and the recording to this webinar. So Lisa, would you please provide us with a couple of comments? And before I hand it over to you, I will just thank all of the participants for your active participation, and thank the panelists for sitting with me in conversation today. It's been very meaningful and illuminating for me. And so thank you very much, Sarah, Lori, Nopiwe, and Barbara for joining us. I'm going to hand it now over to Lisa Hilme to officially close the webinar. Thank you, Lisa.
And thank you so much, Julie, and thanks to all our panelists. What great work. And I think a testimony to everything you're doing is just the reach of this webinar, the questions, and also the engagement people have had, including, nurses that have used, Hesperian guides in rural communities. Like that to me is just amazing. And then seeing some of the work of Stanford Digital Medic, ThinkMD, really great discussions, and really gets us to think about things for the future also, some of the issues that were mentioned. And so it has been recorded, and then we will have it up on the core group website soon. There were some questions about how do we get in touch with the panelists. So if you're interested in sharing your emails in the chat box, we can do that. Or if people want to reach out to me and I can facilitate an introduction, I will put my email in the chat box. Because one of the great things about core group, our mission is collaboration and learning. So that really the point is to make these connections and to elevate the great work of our members. I know that we're pressed for time. It's been a really amazing hour and a half together. So thank you for your time. And we look forward to sending out to the broader community that this webinar will be on the core group website so more people can see your work and hear about it. And just a big thank you to everyone. Thank you for the work you do at the community level. And thank you for being core group members for many, many years, and some of you being new core group members. So I see the heart emojis going up, and I feel it. So thank you very much, and have a great rest of the day.
Thank you, Lisa. Thanks for organizing this. It was wonderful.
Absolutely.